So my topic today is going to be the epidemiology of cancer in Sub-Saharan Africa. And as you know, this, the Sahara Desert right here subdivides northern Africa from Sub-Saharan Africa. So all of the red countries constitute Sub-Saharan Africa, and that is the majority of Africa. And it includes Madagascar. So what are the population characteristics of this area? Well, it's very much an area of diversity, transition, and urbanization. So it's very hard to generalize because there are all kinds of pockets here, but we're going to generalize a little bit, and it may not be absolutely true for your particular community, but this is just statistically in general. The current population is almost 1 billion people, 40% of whom are under the age of 15. 37% live in urban areas. The average family size is 5.6, and it has the highest growth rate of any area in the world, with projected population size of 1.5 billion by the year 2050. Sub-Saharan Africa now accounts for 12% of the world's population, but by 2100 will account for 1/3. And the world population at that time is estimated to be 10 to 16 billion people. So 1/3 of that will be 3 to 5 billion people in Sub-Saharan Africa alone. The demographers like to do their population graphs. And as you can see, we're comparing Uganda here with Italy. They call this the pyramid of Africa and the bulge of Europe. So as you can see here, Italy represents almost like a man with a pot belly and his arms outstretched. And there's a big population right here in the age group of over 65. We see just about the opposite in Uganda, which we use as representing Africa, where the majority of the population is here under the age of 15, with very few people up here over 65. Again, in terms of the ultimate population growth, we have here 1950 up to the year 2000 and 2050. We've actually crossed this point right here where Sub-Saharan Africa growth population has surpassed that of Europe. So the population in Europe is estimated to probably be very stable at about 0.75 billion, whereas the population in Sub-Saharan Africa is continuing to really rise almost to 1.75 billion here. Socio-economic parameters include a child mortality rate that is in some places 15% by the age of 5, an average annual income equivalent to US dollars of $1,351 per year, and 50% of rural areas are without electricity. Well, as you might expect, the GDP and the poverty rate are inversely related. And right here about 2002, the GDP, which is in red, started to climb, and the poverty rate went down. But you're still looking at a poverty rate that at its max was 45%, and is now about 33%, and that is defined as $1 per day living income. So, you know, we have a low threshold here. The cancer incidence in Africa is projected to increase dramatically in the next decade. In 2008, there were 715,000 new cases and 542,000 deaths. It's projected that in 2030, the number of new cases will practically double from this, and there'll be almost 1 million deaths. And WHO predicts that by 2020, 70% of all new cancer cases will occur in the least developed countries. There are some problems with calculating the cancer rates in Africa. The incidence is greatly underrepresented in many countries because there are only about 7 cancer registries, which represent about 6% of the African population. There is also a competition for resources. For example, 45% of the district hospitals lack anesthesia machines. 52% lack a steady supply of sterile gloves. And I am told that even here in our referring hospital that there is not an active CT scanner at this point. There are limited resources for accurate staging. There are limited biopsy facilities, limited mammogram facilities. There are very scarce pathology labs. The general poverty, especially in certain countries, is very inhibitory. For example, in Burundi, the percent of population living on less than $1 a day is 80%. There are funding problems. For example, the United States allocates $8,000 per person per year for cancer care alone. Compare this to $100 per year allocated for all health care, including vaccines, child health care, infectious diseases, everything. There are competing causes of death, and at this time, cancer ranks 7th, even considering the underreporting. So there is a very low life expectancy in certain countries, as low as 45 years in Zambia and Zimbabwe, primarily from the competing causes of death. There are also a huge lack of healthcare workers here. And just to look at this briefly, we look at the ratio of doctors and nurses in this column here per 1,000 of population. And we look, for example, at the United States, where there are 12.3 doctors and nurses per 1,000 people. And then we come down here to Sub-Saharan Africa. It's a ratio of 1.1 doctors and nurses per 1,000. So this is one of the lowest in the world. And in the United States, we have one of the highest. So it's a huge problem of healthcare workers. And this extends all the way from the laboratory technician to the tumor registrars and the pathologists. For example, in Malawi, there is 1 pathologist for 15 million people. And on average, there is a 3-month wait for pathology results. So in consequence, many illnesses are diagnosed clinically, not necessarily based on biopsy or pathology results. And they did a study, for example, of Burkitt's lymphoma in Uganda. And then they sent the samples back to a reference lab, and they found that 75% of patients who were diagnosed clinically with Burkitt's lymphoma actually had it based on the reference lab. So 25% were being treated possibly inappropriately based on the wrong diagnosis. The other problems are that the sources are often out of date, and the data must be extrapolated from sources over 20 years old. And there is a stigma of cancer diagnosis, so that again will lead to underreporting. The WHO bulletin states that for over 250 million adults in the region, the base of knowledge is exceedingly thin. And for non-communicable diseases, essentially non-existent. It is time to recognize that official estimates are at best only approximate within a factor of 10. This shows the reported statistics for Sub-Saharan Africa in terms of illnesses, or deaths, excuse me, and these are the leading causes of death. This is based on 2004 data. So at that time, HIV/AIDS was number 1, lower respiratory infections 2, diarrheal disease 3, perinatal conditions 4, malaria 5, heart diseases 6, and here we see malignant neoplasms, 7. So even taking into account underreporting, probably the rank it will still be somewhat similar. In terms of the percent of deaths in the world, 19.1% is caused by infectious and parasitic diseases. And in Africa, that percent goes up to 52.7%. In terms of cancer in the world, it is responsible for 12.5% of deaths, but in Africa, 3.8%. So you can see that there are many competing causes of death for the scarce dollars that are available. This is a figure just showing the life expectancy at birth in sub-Saharan Africa. And you can see that there are many countries that cluster right around the age of 50. And this is Tanzania right here, the United Republic of Tanzania. So the death statistics are that 80% of the deaths in sub-Saharan Africa occur in people less than age 60, whereas 80% of deaths in the United States are in people over age 60. So it's just the reverse. And because of rapid changes in population composition, aging, westernization, growing obesity, increase in smoking, and other lifestyle choices, the incidence of cancer is projected to increase by 85% by 2030. Based on 2008 data, the top 10 causes of cancer death in females in Africa is reported to be cervix, number 1, breast, number 2, Kaposi sarcoma and AIDS, number 3, liver cancer, number 4, non-Hodgkin's lymphoma, number 5, ovary, number 6, colon and rectum, number 7, esophagus, number 8, stomach cancer, number 9, and leukemia, number 10. And these asterisks indicate that they are not included in the top 10 in the United States. In males, the top one in 2008 was Kaposi sarcoma or AIDS, going on down to liver, prostate, bladder, non-Hodgkin's lymphoma, esophagus, lung, colorectum, and stomach, and then leukemia. So it's reported a little bit differently now in 2013, males and females. These are actually the incidences, 2013. So in females, again, cervix is number 1, followed by breast, liver, colorectum, esophagus, and non-Hodgkin's lymphoma. AIDS has dropped down now to number 7, then lung, ovary, and bladder. And again, in the males, KS has dropped from number 1 down to number 4. And the leading cause of cancer now is estimated to be prostate, liver, esophagus, KS, followed by colorectal, lung, non-Hodgkin's lymphoma, and bladder. And of course, non-Hodgkin's lymphoma is also attributable to HIV in some cases. So the prevalent types of pediatric cancer in sub-Saharan Africa are Burkitt's lymphoma, which comprises 50% of childhood cancers, nephroblastoma, retinoblastoma, Kaposi sarcoma, rhabdomyosarcoma, non-Hodgkin's lymphoma, and Hodgkin's disease. Cancer in sub-Saharan Africa is often related to infectious causes, so much of it is considered preventable. Approximately 1/3 of cancers are known to be related to infection: HIV, HHV8, hepatitis B and C, HPV, schistosomiasis, H. pylori, and possibly a link to malaria and Epstein-Barr virus. This is about double the rate in other parts of the world. 90% of malaria cases are in Africa, and malaria is a major cause of death in children less than 5. HIV and cancer. Of course, this is a very, very important topic. 2/3 of the 34 million people infected with HIV worldwide are in Africa. The AIDS-defining cancers such as KS, non-Hodgkin's lymphoma, and cervical cancer are in the top 10 causes of death in sub-Saharan Africa. And cancer is the cause of about 1/3 of the AIDS deaths worldwide. Kaposi sarcoma is associated with HIV and HHV-8. AIDS has also caused a doubling of cancer in children, with a peak of Kaposi sarcoma seen in children 0 to 4 years of age. With international aid and medication, KS, as you saw, did drop from being the number 1 or 2 on the cancer list, but it's still in the top 10 for both sexes. Cervical cancer we'll hear a lot more about later, but just to give you an overview, it is the most common cancer of women in sub-Saharan Africa. The incidence is 31 per 100,000 women. There are 80,000 new cases annually. The HPV types most commonly seen are 16, 18, 33, 45, 31s, which is similar to the worldwide distribution. However, Kenya, for whatever reason, most commonly has HPV 56, and Zimbabwe HPV 58. HIV positive women are at higher risk of HPV infection, progression, and failure. There are very low incidence of awareness of disease and prevention. In a study of 355 Kenyan women, it showed that only 15% had ever had a Pap test, and 27% of the women with cervical cancer were HIV positive, about 1/3. There are screening programs now using acetic acid for visual inspection, and they seem to have some success in terms of immediate identification of dysplasia, as often it's difficult to trace women after a Pap. Cervical cancer is often diagnosed at a late advanced stage. Many are understaged because of the lack of imaging capabilities, and there is an over 60% mortality rate. The HPV vaccine could prevent 70% of cervical cancer, but the cost of $360 for 3 doses has been prohibitive up until now. However, it's recently reported that Gavi has negotiated a record low price of $4.50 for the 3 injections, and there are plans to immunize 2 million girls in sub-Saharan Africa by 2015. Non-Hodgkin's lymphoma, there are 25,000 new cases per year. Burkitt's lymphoma comprises 25 to 50% of pediatric cancers in Africa, up to 70% in some areas where there are high malaria rates. And usually these are B-cell lymphomas, and they are predominantly high grade. And 1/4 of the cases are linked to HIV or AIDS. Breast cancer comprises 19% of all cancers in African women. There are 65,000 new cases annually and 44,000 deaths. It's often seen at an advanced incurable stage. And in one study listed below, 40% had fungating tumors, 77% were stage 3 or 4. And another study reported that the mean tumor size was 10 centimeters. Well, they showed many photographs of these cancers in the article, but I didn't copy them for you, but I think you can imagine what they look like. But mammogram is not a convenient screening tool because the population is very often nomadic or difficult to trace afterwards. Only 7% of the women receive a lumpectomy, and there's a high percentage of women with actually triple negative cancers which have a more adverse outcome. There are cultural barriers to seeking care. 40% of African women in East Africa would rather seek health care for a breast lump from a traditional healer. And the majority of these women would attribute the cancer to supernatural causes. Liver cancer. Most are hepatocellular carcinomas. There's a disproportionately high incidence in rural Black communities. Mozambique, for example, one of the poorest countries in the world, had the highest incidence of liver cancer in sub-Saharan Africa. The incidence was 58 times higher than for American whites. It's the third most common in cancer incidence in men and the sixth in women. And it's the fifth most common cause of cancer death. It occurs at a relatively young age compared to how we see it worldwide, and the median age is 33. Now, there is a vaccine available for hepatitis B. It's been available since 1982, but it's not been widely used until Gavi, and this is not a promotional piece for Gavi, but I do think they have done a number of very good things, and they started distributing that in the year 2000. Well, hepatitis C was actually given to a number of people by the government in Egypt because they were trying to treat schistosomiasis, but their equipment, unfortunately, was infected with hepatitis C. Aflatoxin B1 is produced by the Aspergillus mold on nuts and grain, and there is a synergistic carcinogenic effect of aflatoxin with hepatitis B virus. Alcohol, HIV, and AIDS, and this is one I don't think we see much at home, but it's called iron overload from home-brewed alcohol. So I guess they must be using iron pots or something to make their liquor in. Prostate cancer consists of 27,000 new cases per year, 10% of all cancers in males. Black Africans have a lower incidence than American blacks. And South Africa has the highest incidence in Africa, 40.1 per 100,000 males. Again, it's often diagnosed at a late or metastatic stage rather than by screening PSA. So there is a high mortality rate. And again, I think we'll have a number of speakers address this issue. Esophageal cancers, the incidence and mortality rate in East Africa is 7 times higher than for other parts of Africa. It may be related to a toxin found in fungal infestations of corn and peanuts called Fusarium moliniforme. And if you've seen how they store some of their corn and peanuts, you can understand why it might be prone to this fungal infestation, because it's just like outside, it's on some kind of a platform and just covered by a tarp, so it's not really that hygienic. So esophageal cancer may also be related to H. pylori infection, tobacco, and alcohol use. Contrary to what we're seeing in the United States, 82% of patients are squamous cell, and usually in the lower third of the esophagus. There is a male predominance. The relationship of cancer incidence to mortality. Here we have Africa versus North America. So here we see the incidence in general, at least has been reportedly, much lower incidence in both males and females in Africa. But when you look at the actual mortality rate, this is almost, comes very close to being a 1-to-1 ratio. It's, maybe 75%. So the incidence is lower, but the mortality proportionally is much higher. There's a wonderful interactive website, and if you have a chance and you like to investigate it, go to this website, Cancer's Global Footprint. And on this website, you can click any country to look at the statistics of incidence, mortality for these various cancers. So you can see here the incidence, again, in the United States is much higher as compared to Africa. And then you go to mortality, and again, you'll see that there's some areas here of mortality which are actually higher than in the United States. And if you click on a particular country, let's say Tanzania, for example, since we are in Tanzania, you'll come up with something like this. So the cancer deaths annually per 100,000 people, 70.2. The Human Development Index is 159 out of 179, 179 being the lowest. GDP per capita is $505 per year. The health expenditure per capita in US dollars, $27. And the life expectancy, 56 years. So say you want to hone in and look specifically at, say, cervical cancer in Tanzania. You can actually click on that country and then click cervical cancer, and you'll get something like this. And you'll see that there are 37.5 cervical cancer deaths annually per 100,000 women. So the relationship of cancer incidence to mortality is this. The probability of developing a cancer in a woman living in present-day Uganda is 30% lower than that of a woman in Western Europe. But the probability of dying from a cancer by this age is almost twice as high. 95% of cancer patients are seen in late or end-stage disease. And to finish up here, this quote from Pezzettini in 2007, "Oncology in Africa seems to be a branch of medicine practiced only by the local healers, procuring devastating effects on the natural history of the tumors." And of course, this conference is about changing all of that. We hope that this new clinic in Moshi will be a beacon of light and hope, ameliorating some of these dire outcomes that we have seen thus far and bringing modern cancer care to thousands of people in this area. Thank you for your attention.